A letter to the Massachusetts Board of Registration in Medicine from Dr. Elena Davila, MD, date March 15, 2024. Subject: voluntary surrender of medical license. To the board members, I am formally requesting the voluntary surrender of my medical license to practice surgery in the Commonwealth of Massachusetts. This decision comes after 15 years as a trauma surgeon at Massachusetts General Hospital, where I have maintained an exemplary record with zero malpractice claims and consistently high patient outcomes. I understand this request requires explanation, particularly given my standing in the surgical community and my recent appointment as Chief of Trauma Surgery. What I am about to document will sound impossible to any rational medical mind, but I have spent the last 6 months trying to find a logical explanation for what I witnessed, and I have concluded that some experiences challenge the boundaries of current medical understanding. The case that ended my career began on February 3, 2024, during what should have been a routine Saturday morning shift. Massachusetts General Hospital's trauma unit operates at the intersection of cutting-edge medicine and human desperation. As a Level 1 trauma center, we see everything from routine appendectomies to multiple vehicle accidents, with victims fighting for their lives. In my 15 years there, I have performed over 3,000 surgeries, from simple procedures to complex multi-organ repairs that lasted 14 hours. I specialized in thoracic trauma, particularly cases involving cardiac injury. The heart, despite its symbolic associations with emotion and life, is mechanically straightforward when damaged. Lacerations can be sutured, penetrating wounds can be repaired, and even complete transections can sometimes be fixed if the patient reaches surgery quickly enough. The physiology is predictable. Stop the bleeding, restore circulation, maintain oxygenation. It is elegant in its simplicity. That Saturday morning started typically. I had been on call since Friday evening, and by 8 in the morning we had handled 2 cases. A motorcycle accident victim with multiple rib fractures and a construction worker who had fallen from scaffolding and punctured his lung. Both surgeries went smoothly, and I was looking forward to a quieter weekend. Dr. Danilos, our chief resident, found me in the surgeon's lounge reviewing the construction worker's post-operative chest films. Dr. Davila, we have a code red trauma coming in. Estimated time of arrival 3 minutes. Adult female, approximately 25 years old, found unresponsive in downtown Boston. Paramedics are reporting possible cardiac arrest, but the preliminary information doesn't make complete sense. I had worked with LOC for 2 years and trusted his clinical judgment. When he said something didn't make sense, it was worth paying attention to. What's the discrepancy? The paramedics found her on a park bench on Boston Common. No obvious trauma, no signs of drug use, no medical alert bracelet. But they're getting inconsistent vital signs. Sometimes they can't find a pulse, then suddenly it's strong and regular. Same with blood pressure and respirations. They have been working on her for 20 minutes and can't establish a stable baseline. That was unusual, but not unprecedented. Some patients in severe shock can have fluctuating vital signs as their cardiovascular system tries to compensate for whatever underlying problem is causing the instability. Any witnesses to what happened? A jogger found her around 7:30 this morning, said she was sitting upright on the bench, but completely unresponsive. No one saw her collapse or fall. She was just there, like she had been placed. We made our way to Trauma Bay 2, where our team was already preparing equipment. The nursing staff included Karina Rodriguez, our senior trauma nurse with 12 years of experience, and Louis Walsh, one of our best surgical techs. Dr. James Wilson, our anesthesiologist, was setting up the airway management equipment. The ambulance arrived at 8:17 in the morning, and the paramedics wheeled in a patient who immediately challenged my expectations. The woman appeared to be in her mid-20s with long auburn hair and pale skin. She was wearing a simple blue dress and flat shoes, the kind of outfit someone might wear to a casual weekend brunch. But what struck me first was how peaceful she looked. Patients in cardiac arrest or severe medical distress have a distinctive appearance. Their faces show the strain of their body's fight for survival. Cyanosis around the lips, tension in the facial muscles, sometimes foam or blood around the mouth. This woman looked like she was sleeping comfortably. Her skin tone was normal, her lips were pink, and her facial expression was completely relaxed. "What's her current status?" I asked the lead paramedic, Maria Santos, whom I had worked with dozens of times. "That's what we can't figure out, Doc. When we first arrived, she had no pulse, no respirations, pupils were fixed and dilated. We started chest compressions and pushed epinephrine. Then suddenly, about 5 minutes later, she had a strong regular pulse and was breathing normally. So we stopped compressions and prepared for transport. But then her vitals disappeared again. We have been going back and forth like this for the entire transport. That was medically impossible. Cardiac arrest is a binary condition. Either the heart is beating effectively, or it isn't. Patients don't spontaneously recover from true cardiac arrest without intervention, and they certainly don't cycle back and forth between arrest and normal cardiac function. I began my primary assessment while the team worked to get the patient connected to our monitors. Her airway was clear, and when I listened to her chest, I could hear normal breath sounds bilaterally. But when I checked for a pulse, I found nothing. No carotid pulse, no femoral pulse, no heart sounds with my stethoscope. "Corinna, what are the monitors showing?" "Nothing consistent. The cardiac monitor is showing a normal sinus rhythm at 72 beats per minute, but the pulse oximeter can't detect a pulse. Blood pressure cuff isn't registering anything." I looked at the cardiac monitor, which clearly displayed a normal, regular heartbeat. But when I palpated the patient's neck and wrists, I couldn't feel any pulse corresponding to the electrical activity on the screen. This was a condition called pulseless electrical activity, where the heart shows electrical function but no mechanical pumping action. It is a serious emergency that requires immediate intervention. "Let's start chest compressions and prepare for advanced cardiac life support," I ordered. Luis began chest compressions while Dr. Wilson prepared to intubate the patient. But as soon as Louis placed his hands on the patient's chest and began compressions, something extraordinary happened. The woman's eyes opened. She didn't gradually regain consciousness the way patients typically do when emerging from sedation or unconsciousness. Her eyes simply opened, and she was immediately alert and oriented. She looked around the trauma bay with calm curiosity, as if she were touring a medical facility rather than receiving emergency treatment. "Please stop," she said in a clear, soft voice. "That's not necessary." Louise paused the chest compressions, and we all stared at the patient. She was now clearly conscious and speaking normally, but the monitors still weren't detecting a pulse or blood pressure. "Ma'am, I'm Dr. Davila. You're in the emergency room at Massachusetts General Hospital. Do you remember what happened to you?" "I'm perfectly fine," she replied, sitting up on the stretcher. "There's been some kind of misunderstanding." I placed my stethoscope on her chest and listened carefully. I could hear absolutely nothing. No heart sounds, no lung sounds. But she was sitting up, speaking normally, and appeared completely healthy. "What's your name?" I asked. "You can call me Anna." "Anna, we need to run some tests. You were found unconscious, and we're having trouble getting consistent vital signs. I would like to do an electrocardiogram and some blood work. I understand your concern, but I assure you that I'm fine. These machines must be malfunctioning." Dr. Wilson had been checking the monitors and equipment while I spoke with the patient. "Elena, I have verified all the equipment. Everything is functioning normally. But look at this." He pointed to the cardiac monitor, which was now showing a flat line. No electrical activity at all. But the patient was sitting up, talking, and appeared completely normal. "Anna, I need you to lie back down. We need to figure out what's happening with your heart." "My heart is fine," she said with a slight smile. "Perhaps your machines aren't calibrated for my particular physiology." I had never encountered anything like this in 15 years of trauma surgery. A patient cannot be conscious and alert without a functioning cardiovascular system. The brain requires continuous oxygen delivery, which is impossible without cardiac output. Yet here was a woman who was clearly conscious despite having no detectable pulse or blood pressure. "Dr. Losi, please call cardiology and ask them to send someone down immediately. And I want a portable echo machine in here right now." While we waited for the echocardiogram equipment, I continued my examination. The patient's skin was warm and had normal color. Her pupils were equal and reactive to light. Her mental status was completely normal. She was oriented to person, place, and time. But when I placed my stethoscope anywhere on her chest, I heard only silence. Dr. Patricia Hawkins from cardiology arrived within 10 minutes, bringing a portable echocardiogram machine with her. Dr. Hawkins was one of the most experienced cardiologists at Massachusetts General Hospital, with over 20 years of experience in both invasive and non-invasive cardiac imaging. "Elena," Danny filled me in on the basic situation. "This sounds like some kind of equipment malfunction." That's what I thought initially, but we have checked everything multiple times. Take a look for yourself. Dr. Hawkins began her own examination of the patient, starting with auscultation. I watched her expression change from professional skepticism to concern as she moved her stethoscope across the patient's chest. "I'm not hearing any heart sounds," she murmured. "Let me try the echo." She applied gel to the patient's chest and began the echocardiogram. The ultrasound image appeared on the screen and we could clearly see the patient's heart. But it wasn't moving. The heart appeared structurally normal, but there was no motion whatsoever. No contractions, no valve movement, no blood flow through the chambers. It looked like a high-resolution anatomical model rather than a living organ. "This is impossible," Dr. Hawkins said quietly. "The heart is not beating, but the patient is clearly perfusing her organs somehow." Anna had been watching our examination with calm interest. "Doctors, I appreciate your thoroughness, but I really am fine. Perhaps it would be better if I simply left and allowed you to treat patients who actually need your help." "Ma'am, I'm afraid that's not possible right now. We need to understand what's happening with your cardiovascular system. This presentation is potentially life-threatening. I can assure you that my life is not in danger." Dr. Hawkins pulled me aside. "Elena, in 23 years of cardiology, I have never seen anything like this. The echocardiogram clearly shows a structurally normal heart with no motion whatsoever. No contractions, no filling, no ejection. But the patient is alert, responsive, and showing no signs of circulatory compromise. Could this be some kind of artifact? Maybe the echo machine is malfunctioning?" "I don't think so. I can see all the anatomical structures clearly. The image quality is excellent. The heart is just not moving." I decided to order a more comprehensive workup. "Let's get a 12-lead electrocardiogram, arterial blood gas, complete metabolic panel, cardiac enzymes, and a chest X-ray. And I want a CT angiogram to evaluate the vascular system." Over the next hour, we completed all the tests. The results were consistent with our clinical findings, but they made no medical sense. The 12-lead electrocardiogram showed a completely flat line. No electrical activity in the heart whatsoever. The arterial blood gas, however, showed perfect oxygenation and normal acid-base balance. The chest X-ray revealed normal lung fields and a heart that appeared structurally normal, but was positioned in an unusual way, as if it were suspended in the chest cavity rather than actively pumping. Most puzzling of all, the CT angiogram showed no blood flow through any of the major vessels. The contrast material we injected intravenously simply pooled in the peripheral veins and never moved toward the heart or through the arterial system. Dr. Wilson had been monitoring the patient throughout these tests, and he reported that Anna remained completely stable. Her oxygen saturation is 100% on room air. Her mental status is normal, and she's not showing any signs of distress. But I cannot detect any vital signs whatsoever. I had Dr. Losi contact our Chief of Staff, Dr. Robert Kim, and explain the situation. Within 30 minutes, Dr. Kim arrived in the trauma bay, along with Dr. Jennifer Walsh from nephrology, Dr. Michael Torres from neurology, and Dr. Amanda Foster from hematology. Each specialist performed their own examination and reviewed the test results. Their conclusions were unanimous. The patient appeared to have no functioning cardiovascular system, yet she was conscious, alert, and showing no signs of organ dysfunction. "This challenges everything we understand about human physiology," Dr. Kim said, after reviewing all the findings. "Without cardiac output, the brain should lose consciousness within 15 seconds. Other organs should begin failing within minutes. But this patient has been stable for over 2 hours now." Dr. Walsh had been reviewing the laboratory results. "Her kidney function is completely normal. Creatinine, blood urea nitrogen, electrolytes, everything is within normal limits. But without blood flow through the kidneys, she should be developing acute renal failure. Dr. Torres completed a comprehensive neurological examination. Cognitively, she's perfect. Normal memory, normal reasoning, normal motor function. But the brain requires 20% of the body's cardiac output to function. What she's demonstrating is neurologically impossible. Anna had been listening to our discussions with apparent amusement. Doctors, you seem distressed by your inability to explain my condition. Perhaps you should consider that your understanding of human physiology, while impressive, may not be complete. What do you mean by that? I asked. I mean that life, consciousness, and the functioning of what you call the human body might be more complex than your current medical models suggest. Dr. Kim stepped forward. Ma'am, we're not trying to distress you, but we have a responsibility to understand what's happening. Your condition appears to contradict fundamental principles of medicine and biology. And yet here I am, clearly alive and well by any reasonable definition. I decided to try a different approach. Anna, can you help us understand how you're able to function without a working heart? Have you always been this way? Not always, no. This is a relatively recent development. Recent how? Days? Weeks? 3 weeks ago, I experienced what you would call clinical death. I was underwater for over an hour. The room fell silent. Dr. Kim stepped closer. That's impossible. No one survives submersion that long without permanent brain damage or death. I was part of an experimental cold water rescue training program. Military-funded research into extreme survival scenarios. The water temperature was 32 degrees Fahrenheit. I was submerged for 67 minutes before they pulled me out. Dr. Torres shook his head. What military program? We would have heard about research like that. The research was classified, testing the limits of human survival in Arctic conditions for special operations personnel. When they recovered me, I had no pulse, no respirations, core body temperature of 71 degrees. I was clinically dead by every medical definition. How did they revive you? Dr. Wilson asked. They didn't. Not in the conventional sense. After 2 hours of failed resuscitation attempts, I simply opened my eyes. My body temperature normalized within minutes. But my heart never restarted in the way yours functions. Dr. Hawkins interrupted. That's medically impossible. Hypothermia can slow metabolism and provide some neuroprotection, but not to the point where you could survive over an hour underwater and then function without cardiac activity. Anna's expression became more serious. What if I told you that extreme hypothermia triggered some kind of metabolic adaptation, that my cells learned to function with minimal oxygen, processing nutrients through pathways that don't require traditional circulation? I had read about theoretical research into suspended animation and hibernation-like states in humans. Are you saying you developed some kind of alternative circulatory system? Not alternative. Absent. My organs function through direct cellular exchange. Each cell has somehow adapted to extract oxygen and nutrients from interstitial fluid without requiring blood flow. It's as if my entire body became capable of functioning like certain deep-sea organisms that survive without traditional cardiovascular systems. Dr. Foster leaned forward with interest. Even if that were theoretically possible, the brain couldn't survive such a transition. Neurons require constant glucose and oxygen delivery through blood circulation. Unless the brain also adapted. What if prolonged hypothermia triggered dormant genetic pathways, evolutionary backup systems that allow human consciousness to persist through mechanisms we don't understand? The human genome contains vast amounts of non-coding DNA that scientists call junk DNA. But what if it's not junk at all? What if it contains instructions for survival mechanisms that only activate under extreme conditions? Dr. Torres was shaking his head. You're describing a complete reorganization of human physiology. That would require changes at the cellular level that would take millions of years of evolution. Or it would require activation of existing genetic programs that evolution already provided, programs that remain dormant unless triggered by extreme environmental stress. There are documented cases of organisms that can survive complete dehydration, freezing, or oxygen deprivation by entering states that suspend normal biological processes. Anna continued, consider tardigrades, microscopic animals that can survive in space, withstand radiation levels that would kill any other known life form, and remain viable after being frozen for decades. They do this by replacing most of their cellular water with protective proteins and entering a state called cryptobiosis. What if humans have similar capabilities locked away in our genetic code? Dr. Kim was listening intently. You're suggesting that extreme hypothermia somehow activated these dormant genetic programs in your case? I'm suggesting that when my body temperature dropped to levels that should have caused death, something extraordinary happened. My cells began producing proteins that I've never seen in medical literature. My metabolism shifted to pathways that don't require oxygen in the traditional sense. My nervous system reorganized itself to function through direct electrical communication rather than chemical neurotransmitters that require blood circulation. The explanation was scientifically implausible but not entirely impossible. There were documented cases of extreme hypothermia survival that defied medical explanation. Research into human hibernation and suspended animation had shown that the human body contained far more adaptive capability than previously understood. Dr. Foster had been reviewing the blood work results more carefully. Elena, I need to show you something. We drew blood from her peripheral IV, and while the cell counts are normal, the cellular structure is unlike anything I've seen. The red blood cells appear to have modified membranes, almost crystalline in structure. And there are proteins in the plasma that don't match any known human proteins. Those proteins are what allow my cells to function without traditional circulation, Anna explained. They act as both oxygen carriers and nutrient transporters, moving through interstitial fluid rather than blood vessels. They're far more efficient than hemoglobin at binding and releasing oxygen. Dr. Hawkins pulled up the echocardiogram images again. If what you're saying is true, then your heart isn't beating because it doesn't need to. Your cardiovascular system has been completely bypassed by this new cellular mechanism. Exactly. My heart remains structurally normal, but it's no longer necessary for survival. It's like having a backup generator that you no longer need because you've installed solar panels. I found myself both fascinated and terrified by the implications. Anna, if this is possible, if humans can undergo this kind of adaptation, then it changes everything we understand about medicine, about human potential, about survival itself. Which is exactly why I've been visiting medical facilities, to see how the medical community responds to evidence that challenges fundamental assumptions about human biology. Dr. Kim stepped forward. Anna, if what you're describing is real, then you represent a breakthrough that could revolutionize medicine. We need to study this phenomenon, understand how it works, potentially replicate it for patients who could benefit. And that's where the problem begins, Anna said quietly. Because once you try to study something like this, once you try to control it or replicate it, you risk destroying the very thing that makes it possible. What do you mean? I mean that some adaptations are deeply personal, triggered by specific combinations of genetics, environment, and circumstance that can't be artificially reproduced. The military program that led to my transformation was shut down after my case because they couldn't replicate the results in other subjects. 3 other volunteers died attempting the same protocol. The room fell silent as the implications sank in. Here was a woman who had survived the impossible, but at a cost that made the knowledge potentially useless for helping others. Dr. Foster spoke first. Anna, regardless of the implications, we have a scientific and medical obligation to document what we've observed. This could lead to breakthroughs in treating cardiac arrest, hypothermia, even aging itself. And what if I told you that some knowledge is too dangerous to pursue, that there are aspects of human potential that should remain undiscovered? Why would you say that? Because I'm not the only person who has undergone this kind of transformation. There are others, and not all of them have retained their humanity in the process. Dr. Kim leaned forward. What do you mean by that? I mean that the same genetic programs that allowed me to survive also changed other aspects of my physiology and psychology. I no longer experience emotions the way I used to. I don't feel pain, fear, or fatigue. I don't age in the normal sense. And I've developed abilities that would terrify you if I demonstrated them. What kind of abilities? The ability to control my body temperature at will, to slow my perception of time, to heal from injuries that would be fatal to normal humans. And most disturbing of all, the ability to sense and influence the bioelectric fields of other people. As she spoke, I felt a strange, tingling sensation throughout my body, as if every nerve was being gently stimulated. The monitors in the room began displaying erratic readings, and the lights flickered slightly. "Stop," I said, stepping backward. "Whatever you're doing, please stop." The sensations ceased immediately, and the equipment returned to normal function. Anna looked at me with an expression that might have been sadness if she were still capable of normal emotions. "This is why I've been visiting hospitals, Dr. Davila. To warn medical professionals about the dangers of pursuing research into extreme human adaptation, to show you that some boundaries shouldn't be crossed." Dr. Kim had gone pale. "Anna, are you telling us that you and others like you pose a threat to normal humans? I'm telling you that when you push human biology beyond its natural limits, you risk creating something that is no longer recognizably human. And I'm telling you that there are people in positions of power who would do anything to acquire these abilities, regardless of the cost in human lives." She stood up from the stretcher and began walking toward the door. "Doctors, you have been very thorough in your evaluation, and I'm grateful for your concern. But now you understand why I must leave." "Anna, wait," I called after her. "If what you're saying is true, if there are others like you who are dangerous, then don't we have an obligation to warn people? To prevent this research from continuing?" She paused at the door. "Dr. Davila, you've just encountered something that challenges everything you thought you knew about medicine and human biology. Are you prepared to spend the rest of your career explaining to skeptical colleagues that you witnessed the impossible? Are you ready to be dismissed as delusional or attention-seeking?" "I don't understand." "I mean that some truths are too dangerous to tell, and some knowledge is too risky to pursue. The research that created me was shut down and classified not because it failed, but because it succeeded too well." "How do we know you're telling the truth about any of this?" Anna smiled, and for a moment, her expression seemed genuinely warm. "Because in about 10 minutes, you're going to discover that every piece of electronic equipment in this trauma bay will malfunction simultaneously. Your hospital's IT department will spend weeks trying to figure out what caused it, but they'll never find an explanation. Why would that happen? Because my presence affects electronic systems in ways that I can't fully control. It's one of the side effects of the bioelectric changes in my nervous system. Consider it proof that everything I've told you is true." She left the trauma bay, and despite our attempts to follow her, security footage showed no record of her leaving the hospital. The guard stations had no record of anyone matching her description exiting the building. She had simply vanished. Exactly 10 minutes after she left, every monitor, computer, and electronic device in Trauma Bay 2 shut down simultaneously. The IT department spent 3 weeks investigating the incident and never found a cause. They eventually attributed it to an unexplained power surge, but the hospital's electrical systems showed no evidence of any such surge. In the weeks that followed, I found myself unable to focus on routine surgical cases. Every patient reminded me of the impossibility I had witnessed, and I began to question not just my understanding of medicine, but my understanding of what it means to be human. I requested a consultation with the hospital's psychiatrist, Dr. Lisa Chang, to discuss what I had experienced. Dr. Chang listened carefully to my account and reviewed the medical records from Anna's case, which documented all of our findings but offered no explanations. "Elena, what you're describing challenges our understanding of human biology, but the medical evidence supports your observations. The question is whether you can continue practicing medicine with the knowledge that there are aspects of human potential that medical science doesn't understand. How do I move forward from this? That depends on whether you can accept uncertainty and whether you can continue to provide excellent patient care, despite knowing that our medical knowledge has significant gaps." I tried to return to normal surgical practice, but I found that every case now carried the weight of doubt. When a patient recovered better than expected, I wondered if their improvement was due to natural healing or something beyond my understanding. When a surgery went perfectly, despite complex circumstances, I questioned whether my success was due to skill or influences I couldn't perceive. The doubt became paralyzing. Surgery requires absolute confidence in your knowledge and abilities. When you're holding someone's life in your hands, you can't hesitate or second-guess yourself. But after encountering Anna, I could no longer trust my own judgment or my understanding of what was medically possible. 3 months after the incident, I decided to take a leave of absence to consider my future in medicine. 6 months later, I made the decision to resign from surgery permanently. I now work as a medical consultant for a health insurance company, reviewing cases and making recommendations about coverage decisions. It is intellectually engaging work that uses my medical knowledge without requiring the absolute certainty that surgery demands. I think about Anna regularly, and I have done extensive research into similar cases. What I have found suggests that encounters like mine are more common than the medical community acknowledges. But they're rarely discussed because they challenge the fundamental assumptions of scientific medicine. I have also researched the military programs Anna mentioned, and while I found no direct evidence of the classified research she described, I did find references to discontinued Department of Defense projects related to human performance enhancement and survival in extreme environments. The details remain classified, but the pattern suggests that Anna's account may have been accurate. Sometimes I wonder if I made the right decision in leaving surgery. Maybe I should have found a way to continue practicing despite my uncertainty. But I know that doubt and hesitation in the operating room can be fatal for patients, and I couldn't risk someone's life because of my compromised confidence. What troubles me most is Anna's warning about the dangers of pursuing research into extreme human adaptation. If she was telling the truth, then there may be people who have undergone similar transformations but lost their humanity in the process. And there may be organizations that continue to pursue such research despite the risks. I have never shared the complete details of this case with anyone other than the medical board, partly because I know how it sounds, and partly because I'm not sure what the implications would be if such phenomena were widely acknowledged in the medical community. But I believe that Anna was right about one thing. Some knowledge comes with a price that may be too high to pay. And sometimes perhaps it's better to acknowledge the limits of our understanding rather than pursue discoveries that could fundamentally alter what it means to be human. I check the medical literature regularly for similar cases, and I have found at least 20 reports of comparable incidents at hospitals across the country over the past 3 years. In every case, the patients demonstrated impossible physiological adaptations, and many disappeared before comprehensive studies could be completed. Many of the physicians involved have subsequently left active clinical practice. I don't know what Anna was ultimately trying to accomplish by revealing herself to medical professionals, but I know that encountering her changed my understanding of human potential and convinced me that some mysteries may be too dangerous to solve. Board members, I submit this letter not as an excuse for my decision to surrender my license, but as a complete account of the circumstances that led to my conclusion that I can no longer practice surgery with the confidence and certainty that patients deserve. I have been honored to serve as a physician, and I remain grateful for the opportunity to have helped save lives during my 15 years in trauma surgery. But some experiences change you in ways that make it impossible to continue as you were before. I hope this account provides adequate explanation for my request to voluntarily surrender my medical license. I am available to answer any questions the board may have about my decision. Respectfully submitted, Dr. Elena Davila, MD, former Chief of Trauma Surgery.